We will have an email that you can send questions to at the end. And so we'll be able to do that. Again, if you have questions, we'll put an email address. We'll get to that on the next slide once we get started. Thanks again for joining us. We'll get started in the next few minutes. Once we hit the top of the hour. Welcome to the session today on the new SAMHSA evidence-based resource guide on addressing burnout. We'll go ahead and get started. Welcome everyone to this SAMHSA and MHTTC hosted webinar on the new evidence-based resource guide on addressing burnout in the behavioral health workforce through organizational strategies. Thank you all for attending today. A few housekeeping items. We have made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up using your registration information. We do not have the chat feature enabled today or the Q&A pod, which you might be used to. For questions for the speakers, please email ebprc@samhsa.hhs.gov. If you have questions, that's the place to email. So if you have questions, please go ahead and send them to that email. At the end of today's webinar, we're going to ask you to complete a brief survey. Because we're SAMHSA funded, we want to get your feedback on how to provide you better services in the future. Following the session, you'll get an email on how to access a certificate of attendance if you attend at least half of today's session. The event is closed captions. To view the captions, click the arrow beside the CC box at the bottom of your screen and choose Show Subtitles so you can access the closed captioning that way. Please follow us on social media, MHTTC Network. We're on Facebook and Twitter. And the session is being recorded and all the materials will be posted on the mhttcnetwork.org website within 1 week. So you will get access to the recording and the slide deck after the session. Again, if you have questions, please reach out to ebprc@samhsa.hhs.gov. Next slide. A disclaimer that we are providing this webinar through funding from SAMHSA and that the opinions expressed herein are the views of the speakers. Next slide. So I'm Heather Gotham. I'm the director of the Mental Health Technology Transfer Center Network Coordinating Office. We are a network of 12 centers that provide training and technical assistance to the behavioral health workforce. And you are invited to take a look at the map on this slide and see where your regional center is. The MHTTC network is made up of 10 regional centers that cover all the states and territories, as well as 2 national focus area centers, one on American Indian and Alaska Native populations and one on Hispanic and Latino populations. And also, as I said, I'm from our network coordinating office. So please give a look at our website and connect with your regional center or your national focus area center and check out all of our services. Again, we provide free mental health prevention, treatment and recovery service, training and technical assistance to the mental health workforce. Next slide. Thank you. We want to recognize that our network and our speakers really try to use affirming, respectful, and recovery-oriented language in all of our activities. These are our values and our mission, and we really want to show our respect, our being non-judgmental, using person-first language that's free of labels. So we invite you to do the same. And the next slide. Without further ado, I'm going to turn things over to Humberto Carvalho to get us started today. Thank you.
Thank you, Heather. Next slide, please. Welcome, everybody. My name is Humberto Carvalho, and I'm a public health advisor from the Substance Abuse and Mental Health Service Administration. I'm pleased to kick off this webinar about an important new guide from our evidence-based resource center addressing burnout in the behavioral health workforce through organizational strategies. During the next hour, we will learn about the process to develop the guide and the research included. We'll also hear from a member of the technical expert panel who provided guidance throughout the guide development process, and from 3 members of organizations featured as case studies who will discuss the interventions they implemented to address burnout at the organizational level. Next slide, please. This guide was developed under the leadership of SAMHSA's National Mental Health and Substance Use Policy Laboratory in collaboration with the Centers for Mental Health Service, Substance Abuse Prevention, and Substance Abuse Treatment. The guide is one in a series of guides that cover several diverse topics. To date, SAMHSA has released multiple guides on a range of topics related to substance use and mental health. Guides are shown on the slide and available in the SAMHSA store website. This year, we are working on 5 additional guides, including this one. SAMHSA's vision and the underlying foundation for the guides is to reflect science rigor and make recommendations from the evidence base, provide expert consensus, be comprehensive and modular, so practitioners, administrators, and other stakeholders will be able to use the guide in its entirety or just the sections relevant to their needs. Each chapter will stand on its own and be accessible to the field. We're pleased to announce that this guide addressing burnout in the behavioral health workforce throughout organizational strategies is posted at the SAMHSA store website. To speak more about the guide, I'd like to introduce Dr. Ellen Childs, Senior Associate at Abt Associates and the lead for this guide.
Thanks, Humberto. Next slide, please. So let's start with the basics. What is burnout? The World Health Organization defines burnout as an occupational phenomenon conceptualized as resulting from chronic workplace stress that has not been successfully managed. Burnout is not a medical or mental health diagnosis. It is distinct from, but can be exacerbated by, mental disorders such as anxiety and depression, general stress, job dissatisfaction, secondary and vicarious trauma, and compassion fatigue. Burnout is typically characterized as having 3 dimensions. First, sustained feelings of exhaustion, including loss of energy, feeling depleted and overextended, and feeling fatigued. Second, depersonalization, which involves feeling withdrawal, increased mental distance from one's job, and feelings of negativism or cynicism about one's job. Third, professional inefficacy, or reduced feelings of accomplishment and productivity. The WHO noted that burnout applies strictly to occupational settings and does not apply to experiences in other aspects of life. Addressing burnout may include strategies to impact the symptoms of burnout, but as a workplace phenomenon, improving burnout requires system and organization level solutions. Over 50% of behavioral health providers experience symptoms of burnout. The nature of behavioral health work, which often involves helping individuals manage mental health issues, substance use, trauma, or behavioral health crises, can be emotionally taxing. The behavioral health workforce experiences high levels of work-related stress, relatively low salaries, high student loan debt, and full caseloads. These combined factors place individuals working in the behavioral health field at high risk for experiencing burnout. In addition, the high rates of burnout have been exacerbated by the COVID-19 public health emergency. Next slide, please. The causes of burnout can occur at organizational, interpersonal, and individual levels. Organizational factors are increasingly recognized as the primary contributors of burnout. A broad range of employees in a 2018 poll identified that the top 5 reasons for burnout were unfair treatment at work, unmanageable workload, a lack of role clarity, a lack of communication and support from their manager, and unreasonable time pressure. Although these organizational level factors are the root contributors, symptoms of burnout can be exacerbated by interpersonal relationships, individual experiences, or personality. Depending on the situation, interpersonal relationships with clients, families, and colleagues can provide mediating effects or can create additional stressors that contribute to burnout. Personal family-related obligations and work-family conflict can create additional role pressure, also called role strain, and additional demands on individuals, leading to burnout. Next slide, please. This evidence-based resource guide focuses on organizational strategies to address burnout. Organizational level factors such as excessive workload, lack of transparency in policies and procedures, and low role autonomy are stronger predictors of burnout than our individual level contributors. Organizational approaches to remedy burnout target the root causes of burnout, such as emotional exhaustion, work-related attitudes, and organizational culture and climate. Individual level strategies typically help to address or mitigate symptoms of burnout. Individual level approaches are important for personal resilience and managing stress. However, interventions targeting the symptoms of burnout have limited long-term impact than when combined with organization level interventions. Organizational strategies have the potential for a more enduring impact on reducing burnout because they affect all staff and place the accountability on the organization rather than on the individual. Scaling up effective organization level strategies has the potential to reach more people and have a greater impact than individual level interventions. Next slide, please. So the goals of this guide are to review the literature on organization level strategies to address burnout in the behavioral health workforce, to distill the research into recommendations for leaders and staff to implement, and to provide examples of how other organizations have implemented strategies to address burnout. The audience for this guide includes clinical leadership, administrators, human resource professionals, and employers. The target population served by the evidence and strategies discussed in this guide are mental health and substance use providers and other behavioral health staff who work in organizations. Next slide, please. As a framework for this guide, we use the Later and Moslock 1999 6 areas of work-life model for the organizational context of burnout. At the organization level, conditions that contribute to burnout can be classified into 6 core domains: workload, control, reward, community, fairness, and values. We will revisit this framework when we discuss the strategies discussed in this guide later on in the webinar. Next slide, please. This evidence-based guide includes 5 key chapters. Chapter 1, the issue brief, is an overview of the prevalence of burnout among the behavioral health workforce, what factors contribute to burnout, and the implications of burnout. Chapter 2, what research tells us, describes current evidence on organization-level interventions to produce and reduce burnout, highlighting 5 interventions identified in the systematic literature review. Chapter 3, identifying and implementing emergent strategies to address burnout, includes considerations and practical information for providers, staff, and organizations to consider when implementing organization-level strategies to address burnout. Chapter 4, Examples of Organizations Implementing Evidence-Based Interventions, describes 3 case studies of programs that use practices from chapters 2 and 3 to implement organization-level approaches to address burnout. And finally, Chapter 5, Resources for Evaluation, provides guidance and resources for evaluating organization-level strategies to address burnout and monitor outcomes. In developing this guide, we started by working with our colleagues at SAMHSA and our subject matter expert, Dr. Karen Stam from the American Psychological Association, to identify the goals, audience, and target population for this guide. We identified scholars, practitioners, and implementers who had expertise in burnout and in implementing evidence-based or evidence-informed interventions to address burnout at the organizational level to be on our technical expert panel, or TEP. The TEP included people from social work, psychology, psychiatry, and health services research, and engaged individuals with clinical and applied experience and from other federal agencies. Additionally, members from the behavioral health workforce provided frontline expertise to the TEP. We conducted a systematic literature review of organization-level interventions that led to a statistically significant improvement in burnout outcomes and identified evidence-based or evidence-informed strategies to reduce or mitigate burnout that organizations can undertake. We identified 3 case studies of organizations that have implemented organizational level interventions to address burnout. And finally, we collated tools and resources to support evaluation. Next, I'd like to introduce Dr. Candice Chen, Associate Professor in the Department of Health Policy and Management, George Washington University, who is one of our TEP members. Dr. Chen has extensive research and programmatic experience related to the clinical workforce education, training, and ongoing needs of the health workforce. Her work has focused on workforce needs in underserved communities and workforce diversity, important lenses she consistently brought to her role as a TEP member. Candice?
Thank you, Ellen, so much for this opportunity to just share some thoughts from being a member of the technical expert panel. And the first, I think, that is really important is why I was drawn to this work, and I think why many of the other TEP members were drawn to this work, and that is the very important focus both on the mental health workforce, which as somebody who spends a lot of time thinking about health workforce overall doesn't get nearly enough attention. And second is the real focus on organizational interventions over individual level interventions. And not to say that those individual level interventions, the addressing mental health, for example, for our health workers aren't important, but I think it's the real grappling with this issue that we need to start changing the organizations and systems around people so that we prevent burnout and moral injury rather than, as you put it, just treating the symptoms. The second thing I would think is that, you know, as you went through the chapters and highlighted what the research tells us, really struck me as we were meeting and reviewing the guide was how relatively limited the research and evidence supporting organizational level efforts and change is, and how when we went to identify some of the model organizations, particularly focused on the mental health workforce, that are doing work in this space in making organizational change, we struggled a little bit. And what it says to me is that there's just so much more work to be done, that we're early in this space and it needs a lot more attention and a lot more investment at all levels. The third kind of observation that really struck me as we were meeting and the discussions of the technical expert panel was the need to recognize and really focus on diversity, equity, and inclusion as a core part of addressing burnout. That the experience of burnout by health workers from different groups may be different, and we have to put an equity lens on this work as much as we have to put an equity lens on when we're delivering healthcare. And that in addition to the different experiences of different groups, that the very experience of discrimination based on our race, ethnicity, based on our gender identity or gender, based on our background, is a real potential driver of burnout as well. And we note that in the healthcare space, we can experience that discrimination from patients or clients. We can experience it from our peers, and we can experience it from leadership and the structures around us that may be driving and or allowing that discrimination. And one of the things that really struck me in our conversations was the need to consider the specific workers and the experiences that we have in this space. It really struck me when people talked about peer support workers. And given the experiences that bring them into the space of being a peer support worker, that might also put them at an increased risk for discrimination in the work that they do. And so to really grapple with these issues of diversity, equity, inclusion, and what they look like specifically in the mental and behavioral health and substance use service space. And the final thing is perhaps related to some of that was a good amount of discussion, I think, on really recognizing the role of the external environment and the policies that drive organizational behavior and burnout. I think the Surgeon General's advisory that was released earlier this year really brings some important focus to this issue and to the need to think beyond the individual to the organizations, but also to the drivers outside of organizations that need to be identified, addressed, changed. And I think that we need to recognize that in the mental health substance use space, that this has been a real challenge, that this space has been facing ongoing societal stigma that many are working very hard to change, and in part related to this stigma, as well as other driving factors, that mental health and substance use has seen a real historical underinvestment, and that we continue to be affected by shortages or by, on the opposite side, the sufficiency of the workforce and resources in this area. And it's in this challenging environment that mental health workers currently exist and have to deliver care. And we cannot ignore that until we sufficiently address the societal, the policy, the environmental drivers, that our mental health workers will continue to struggle in these systems. And so, Ellen, it's back to you. I'm really looking forward to hearing the rest of the presentation.
Thanks, Candice. In chapter 2, next slide, please. In chapter 2, we report the findings from a systematic literature review we conducted to identify research articles that fill the following criteria: that the article describes an intervention, program, or policy that was implemented in an organizational setting, such as a health center or a psychiatric hospital; that the intervention is intended to address burnout or related topics, such as emotional exhaustion or compassion fatigue or moral injury; and that the article was published after 2002, was written in English, and was conducted in the United States, the United Kingdom, Canada, Australia, or New Zealand. From the initial database search of 2,269 articles, we identified 12 programs that fit our inclusion criteria. We reviewed those articles and abstracted information into a review table, which is Appendix 3 of the guide. Of those 12, 5 programs were found to be organization-level interventions that showed a statistically significant improvement in the measures of burnout within a healthcare setting. Next slide, please. All 5 programs followed a similar model that is shown here. First, they conducted needs assessments to identify needs from across staff and obtained buy-in from leadership to implement the program. Then they developed a multidisciplinary team to identify challenges and targeted solutions for improvement. They identified priority interventions to implement based on needs, and identified ways to institutionalize practices and program change for sustainability. Finally, they monitored progress, revised plans, and continued implementing new interventions. More information about the articles identified in the systematic review is included in Chapter 2 of the guide. Next slide, please. Chapter 3 of the guide focuses on particular strategies to implement interventions that address burnout at the organization level. We begin chapter 3 with the high-level steps to plan and implement organization-level processes to address burnout, following the literature described in chapter 2. We highlight again the importance of developing a planning and implementation team, conducting a needs assessment, and identifying available resources to support implementation. For example, local experts in mental health or workforce change initiatives, other parallel initiatives occurring at the organization, and so on. We also highlight the importance of building leadership support, identifying potential solutions to identified challenges, and planning for sustainability. We developed this guide with modularity and adaptability in mind. Some organizations may have more funds and internal resources to support these interventions, while others may have less. Either way, for an organization to seriously implement interventions to address burnout challenges, they need to follow these steps. Engage a diverse and multidisciplinary group, understand the organization's need, identify available resources and viable solutions, and plan for long-term sustainability. Next slide, please. Chapter 3 continues with specific strategies to mitigate, reduce, or even prevent burnout. Burnout and its consequences are associated with both organizational culture, or the way that work gets done based on shared norms, and organizational climate, the employee's perception of the work environment. As discussed earlier, burnout can be related to multiple factors within the 6 areas of work-life model, so it is imperative that organizations know the causes of burnout amongst their staff to take concrete steps forward. In this guide, we list examples of strategies for each of the 6 areas of work life. The first strategy, workloads, includes caseloads, paperwork, and availability of administrative support, and all of those things can contribute to burnout. Addressing workload issues may mean reassigning or retraining existing staff to ensure work is appropriately matched to skills, hiring additional staff for appropriate roles, or working with staff to identify and reduce inefficiencies. While hiring new staff may be challenging financially, strategies such as leadership understanding and documenting the entirety of staff's work, including documentation and other non-billable work, can help staff to feel more validated and acknowledged. Next slide, please. The area of control includes that staff may feel that they have autonomy and decision-making ability. Stressors can arise when staff do not have control over their workload or access to the resources that they need to do their work. Strategies within this area include ensuring that staff have resources and support, such as clinical supervision or peer consultation. Engaging staff from all levels in planning and implementation of change can be an important way to ensure that staff feel they have autonomy in decision-making. Next slide, please. The area of reward includes satisfaction with rewards acquired at work, such as pay, benefits, promotions, and praise. Inconsistent or inequitably distributed rewards and recognition will contribute to an employee feeling that their work is unimportant or undervalued, which can affect both staff retention and burnout. Organizations should strive to create a culture where staff know that the organization recognizes and values them. Strategies in this area include creating transparent avenues for promotion and increasing pay, creating systems of staff appreciation that are both genuine and meaningful to staff, and expanding or offering benefits to mitigate work strain, such as childcare or transportation. Next slide, please. Community includes the quality of a social environment within the workplace. A shared sense of community creates an environment where staff feel supported. A lack of trust and unresolved workplace conflict can lead to feelings associated with burnout. Strategies include creating opportunities for building a shared community, cultivating teamwork and camaraderie among staff, developing and implementing policies that are intentional and equitable, addressing stigma within the organization to create a culture of support and understanding, and developing and retaining leaders who encourage adaptive and supportive change. Next slide, please. Fairness includes whether includes the sense of whether staff are treated in a just way. Organizational fairness is impacted when employees do not trust their leadership, including direct supervisors and executives, or when they feel that leadership does not maintain an appropriate level of transparency. Strategies to support fairness include committing to transparency across the organization and developing policies, procedures, and infrastructure to facilitate and sustain positive practice change. Next slide, please. Finally, values is the degree of alignment between an employee's and an organization's values. When employees and organizations' values are misaligned, employees may feel less connected with the organization and their work. Affirming the values of the organization's work and the key role that employees play in the work can signal to employees that their personal values are aligned with those of the organization. Strategies to support values include aligning organizational changes with its mission and aligning performance goals and individual staff metrics with the values and missions of the organization. More details, specific examples, and suggested resources are listed within Chapter 3 of the guide. But to hear more examples, we turn now to the 3 case studies highlighted in Chapter 4. Next slide, please. First, we have an example from the COPE Columbia program at Columbia University Irving Medical Center. This example describes how the Department of Psychiatry implemented a peer and faculty-led initiative to foster well-being and resilience in the wake of the COVID-19 public health emergency. I'd like to introduce Claude Mellons, Professor of Medical Psychology at the Columbia University Irving Medical Center and co-founder of and Program Director of COPE Columbia. Claude?
Thank you so much. It is such a pleasure to be here to present the work of COPE Columbia, which is dedicated to supporting the emotional well-being of our providers, faculty, and staff at Columbia University Irving Medical Center. And I want to just briefly set a context, which is always important. COPE Columbia was born 2.5 years ago in a public health crisis, as New York City was slammed by the first surge in COVID cases in March 2020. Our medical center was one of several New York City ground zeros, inundated with cases, mounting deaths, unclear transmission routes, and no known treatment or vaccine. We knew from previous pandemics and disasters that the psychological footprint would far exceed the medical. Thus, there was a clear need to support our faculty and staff, particularly frontline providers. So based on a request from the medical center and our psychiatry department chair to help those on the front line, COPE Columbia was created by 2 psychiatrists, Lou Baptista Neto and Laurel Mayer, and myself, a psychologist. We knew, as you were just hearing, that there would be tremendous stigma about mental health, about asking for help, about being vulnerable, particularly among physicians. So we quickly brought in 10 to 12 psychiatrists and psychologists from our department with expertise in stress and trauma, loss, grief, burnout, and evidence-based mental health treatment to help us think about how we could create something that would be helpful, accessible, and very importantly, acceptable. We ultimately decided to come in as peers with an ability to translate evidence-based mental health practice into everyday language using a quite simple model. 1, provide psychoeducation on what we know about the impact of pandemics, trauma and loss, grief and burnout. 2, provide the space for people to express what's challenging and stressful, and then label, validate, and normalize their emotions and experience. And finally, help them identify coping strategies and ways to promote well-being, including things like mindfulness, engaging in self-care, recommitting to values, finding hope, and very importantly, creating support systems. We provided and continue to provide this peer support model through several mechanisms, relatively brief individual or group peer support sessions that are confidential. We don't bill or take notes, but we can fast track people for mental health services if needed. We also give town halls and webinars on topics related to stress, trauma, grief, resilience, coping, parenting, and reducing anxiety and burnout. And to reach those who might not have the ability to take time off or feel comfortable coming to any of our events, we created a website with resources in these areas, as well as ways for them to obtain more formal mental health treatment if needed. We also learned quickly that there was a need for our services beyond frontline providers, as in some ways we're all on the front lines of this pandemic, including all of us in behavioral health. So since inception, we have reached over 12,000 faculty and staff across the medical center and the university. Another important lesson that we learned was that there are other threats to well-being besides COVID. So we created brief written guidelines and toolkits for leaders and managers to promote discussions of challenging topics. For example, on things like election or political stress, managing racial and social injustice discussions, modeling ways to talk about experiences of racial stress and bias, and addressing employee concerns about transitioning back to in-person work. There are a few other very key important lessons from this work to date. Perhaps the most important is using peer-to-peer support for clinicians is an underutilized strategy for supporting the healthcare workforce. We were all affected by this pandemic. By using mental health providers as peer supporters, we're able to bring in diverse offerings and services based on evidence-based approaches. And it has allowed us to decrease the stigma of asking for help and increase pathways for outreach, as well as access to more mental health treatment when needed. A second lesson is that trust is key to getting started. It was critical to earn the trust of leadership, but also people on the ground and at the front lines, and to have products such as our toolkits and guidelines that could be used to support well-being. Burnout and other threats to well-being were issues way before COVID, as the previous speakers have indicated, but COVID provided a window of opportunity to demonstrate the importance of addressing burnout and workforce well-being and mental health. So we now have a new chief well-being officer, and resources are being dedicated to this issue at our institution. And then finally, to make well-being a mainstay of our system, many different groups need to be involved. Many groups define wellness as important to their work, and we can accomplish more when we work together rather than alone or in competition. So we are increasingly fostering collaborations with groups such as our human resources, employee assistance programs, and diversity, equity, and inclusion groups to promote well-being in an ongoing way within our workforce. Our long-term goal is to contribute to an inclusive and compassionate culture for faculty and staff at our medical center and the larger Columbia community. I want to thank SAMHSA for focusing on this critical topic and giving us the opportunity to highlight our work, the COPE Columbia team who made this possible, and my collaborator on this case study, Erin Engel. Thank you.
Thank you so much. Next slide, please. All right, second, an example from the Clinician Health and Wellbeing program at the University of California, Davis Health. This example describes how they launched the Clinician Health and Wellbeing program and institutionalized the leadership role of the Chief Wellness Officer to have a more centralized and coordinated approach to support the well-being and mental health of staff across the organization. I'd like to introduce Peter Yellowlees, Distinguished Professor of Psychiatry and the first Chief Wellness Officer at the University of California, Davis Health. Peter?
Thank you very much indeed. And it's a real pleasure to be here. And I certainly want to thank SAMHSA for all the work they've done creating this really important guide. The University of California, Davis Health is an academic medical center serving Northern California and in several other states. We have actually had a clinician health and wellbeing program since about 2018, so well before COVID started. Two challenges led us to starting this program. The first is we were doing quite a lot in terms of clinician health and well-being, but it was fragmented and siloed, and there really wasn't a sort of a core set of funding or a coordinated direction. Secondly, we knew from all of our surveys, as it has been the case with many hospitals and health systems, that we had high physician workloads, a lack of work-life balance across all of our staff, and there was continuing concern about well-being. Now, what have we done in the last 3 years? We've found three things have been particularly useful. The first is actually to develop a critical mass of interest and expertise in well-being among our own staff, so that they can in fact create momentum for continuing change and improvement. We did that by starting a fellowship program, which is a 6-month program. We're now in the 4th iteration of that program, and we've trained about 160 people around the country, including 40 to 50 of our own staff. And we now have a very significant critical mass of people from multidisciplinary backgrounds who are extremely knowledgeable about well-being generally, and particularly about the organizational issues involved in improving a system's culture. The second thing we focused on was establishing multiple pathways for care for any clinicians and normalizing help-seeking behaviors to reduce stigma. We have quite a number of approaches to providing care, including EAP services that in fact over 200 of our physicians per year use. We added 2 full-time clinical psychologists during COVID. We have a very active peer responder program, as was talked about at Columbia, but we've been doing actually for about 10 years now. We have now trained over 600 of our staff to work in that program as well. And we also have a self-assessment tool for suicide prevention, provide professional coaching, and have confidential faculty services for psychiatrists, for psychiatric services, I should say. And finally, we leveraged the Stanford model of professional fulfillment as a framework to improve our own culture and develop a greater culture of wellness. We have provided many care packages and support for people during COVID. We've increased the number of recognition and awards and efficiency improvements we've done. And we have spent a lot of time on communicating with all of our staff with a very successful good stuff message that goes out several times per month on a regular basis to our staff. So what have we learned during this time? Well, we've learned a lot. The first is that leadership buy-in is absolutely critical if you want to support culture change. And we've been very fortunate with that at UC Davis. It was really important to develop a critical mass of expertise within our own program and health system. And I think that's made an enormous difference because these people are now moving through their own careers and using well-being as a component of their careers as they continue forward. And finally, the CWO role was really important, but was certainly not enough in itself. And really the main role of the CWO ended up being an influencer, someone who could influence other members of the leadership, who could coordinate, but certainly not enough in its own. And the CWO needs a team and needs support and needs to be able to access leadership. So it's really good to be here today. Very pleased that UC Davis Health has been used as an example here at the national level, and delighted with the overall output of this particular piece of work.
Thanks, Peter. Finally, an example from the Mental Health America of Northern Kentucky and Southwest Ohio. Next slide, please. While the first 2 examples feature large healthcare organizations, this example describes how smaller organizations can partner with local agencies like Mental Health America of Northern Kentucky and Southwest Ohio for support with implementing strategies to address burnout and promote workforce mental health. I'd like to introduce Amanda Shaw, Program Director of Mental Health and Criminal Justice at Mental Health America of Northern Kentucky and Southwest Ohio. Amanda.
Thanks so much, Ellen. Good afternoon, everyone. Thanks for joining us here. As Ellen stated, my name is Amanda Shaw, and I'm the Program Director of Mental Health and Criminal Justice at Mental Health America of Northern Kentucky and Southwest Ohio. Mental Health America of Northern Kentucky and Southwest Ohio is an affiliate of a larger organization, Mental Health America, which is a nonprofit dedicated to promoting good mental health. We have the unique experience of being a very small organization ourselves. We only have about 40 employees, and we provide prevention, education, and safety net services, as well as serve as a resource hub to the underserved communities in our area, including rural and non-rural counties and to medically underserved populations. So our agency took a 3-pronged approach to addressing burnout and reducing workplace stress and fostering resilience, both using our own agency as an example and partnering with agencies in our community. First, we made efforts to increase awareness about burnout and other mental health conditions by promoting the use of our national MHA online screening tool. The screening tool helped identify symptoms of mental health conditions and directed our users to information, resources, and tools to help improve mental health. Included in the screening is a workplace mental health screening. And as a result, in awareness activities in calendar year 2022, we've had over 10,000 screenings completed just in our small Northern Kentucky, Southwest Ohio service area. MHA National also provides toolkits that we use both internally and externally to ensure we're using best practices. And so those toolkits include things like Mental Health Month Toolkit and a recently released Workplace Mental Health Toolkit. Secondly, we partnered with local nonprofit agencies and experts to provide a variety of burnout and stress reduction trainings. So these trainings were planned to address holistic needs of the attendees and included formal evidence-based trainings like trauma responsive care services, skills-based resilience trainings, and then more informal trainings for like healthy eating as when you're a community mental health case manager and you're on the road all day, as well as like tactical breathing to use for your 2 minutes between therapy patients. Our third kind of prong of our plan was to implement embedded wellness coaching within community agencies to provide one-on-one support to workers when they needed it most. And we focused these wellness coaching services in smaller agencies and underserved communities who did not have the capacity or funding to support wellness coaches on their own. So for example, we partnered with an emergency medical service in a rural county, actually the only emergency medical service in that county. We also were able to provide wellness coaching, in-house wellness coaching to a local private nonprofit behavioral health hospital who had very high turnover, had some very serious mental health concerns among their staff, and really were able to use these smaller agencies and focus on eliminating barriers and enhancing capacity as a partnership. So during our time, we learned that this work, we must do two really big things. First is we must plan services to meet individuals and agencies where they are. That means that a short-staffed behavioral health unit may not have the capacity for nurses or personal care assistants to leave the unit to utilize any of our wellness coaching or resilience training. And so we needed a plan to implement those services on the unit. We also do a lot of work with first responders and public safety, and those workers work all shifts 24 hours a day. And so we needed to be able to plan trainings so that the people who work those shifts can train while they're on their shift instead of asking them to work longer hours or come in on a first shift when they typically are working thirds. Meeting people and agencies where they are also meant taking into consideration where the agency was culture-wise. So we developed a needs assessment that each employee filled out to tell us where they were as far as learning about and combating workplace stress, and then allowing those same employees to tell us what would help them the most. We used that survey in order to make an individualized plan with each agency that we partnered with. And so that plan was developed based on the needs assessment that the employees completed. The second and most important thing that we learned was that, Mental Health America of Northern Kentucky and Southwest Ohio, we identify as sort of a connector and convener. And we do so because we have learned this really important lesson that we can't do it on our own. We learned that in order to combat workplace stress and burnout, we really had to address capacity issues and other barriers. This problem is bigger than our small 40-person agency and bigger than a lot of the smaller agencies that we have partnered with. And we realized that we could not accomplish this work on our own. This meant we had to partner with agencies for all pieces of our plan, which was the training, the awareness efforts, for coaching, for support. And so while myself and Mental Health America of Northern Kentucky and Southwest Ohio are very grateful and happy to be part of this guide, we would be remiss if we didn't acknowledge that we could have not done this without the collaboration and efforts of our partner agencies. Here in Northern Kentucky and Southwest Ohio, community is the key to success. Thanks.
Thanks, Amanda. Next slide, please. So the guide concludes with Chapter 5, Resources for Evaluation, that includes guidance and specific resources and tools one could use to evaluate interventions to address burnout. So to conclude, we are so proud to announce that this guide, Addressing Burnout in the Behavioral Health Workforce Through Organizational Strategies, is now available on the SAMHSA store. You can go to the SAMHSA website and search burnout, or you can follow the URL on the screen or in the chat. We have posted both the guide and a 2-page overview of key findings of the guide to the SAMHSA store. For more information, please contact us at ebprc@samhsa.hhs.gov. Thank you so much for your attention, and back to you, Heather.
Thank you, Ellen. Thank you to all of our amazing speakers today, Ellen and team, for the work you did on the guide, and speakers for your great experience and examples of using this and doing this work in the field. For next steps, we have a brief survey we would love you to complete. Please provide your feedback, positive, negative, whatever it is, our feedback about this session, and will allow us to plan better sessions for you in the future. So it's a very quick survey. It'll take like 2 minutes. Within a week, you'll receive a recording of today's presentation that will be available on the mhttcnetwork.org website. And if you attended today and attended at least half of the session, you'll receive a follow-up email again within the next week with instructions for downloading a certificate of completion. The link to the guide is in the chat. The link to the survey is also in the chat. And you also have the email if you have any questions or comments or thoughts about the session today, or questions for the presenters and the developers of this guide. Please do email ebprc@samhsa.hhs.gov. Thanks again to our speakers, and thank you so much to SAMHSA for sponsoring this incredible work. We really appreciate this kind of support in the field. So please go out and use the guide and do good work. Thank you very much.